Doctor, you see, it's quite different from working in the routine clinic. The patient comes to you normally for a problem with their shoulder. Will you damage shoulder only? Patient comes in a formal emergency, we are able to see. We often recommend we often got recommended. And in a emergency setting, a person who makes the most of the noise get their attention first, the tradition. So it also happens in a situation where you have multiple injuries in a given patient. So it's all about missing the hooks and feet.
Thank you, sir. Respected seniors, my colleagues, I am Ram from Department of Orthopedics and Nutrition Professor. And as sir has said, we are presenting an interesting case. It seems straightforward to start with, but it took an unexpected turn when it went forward. So I request Dr. Abhijit, he's our arthroplasty fellow, to present a case before we start a discussion and what were the suspenses in this case.
Thank you, sir. Good afternoon to all of you. So, it is a case of 45-year-old male who suffered a road traffic accident. He was riding on a bike and he was hit by the moving bus. Then he was taken into a nearby hospital. He was taken into the nearby nursing home somewhere in Dehradun. Now, this is his initial X-ray, where we can see he has suffered a fracture of the lateral tibial proximal tibia and patella. Now, the fracture looks very less displaced, but the injury was so massive for the soft tissue, there was a massive soft tissue swelling. So, initially, he was treated with this spanning external fixator to provide temporary stabilization of the fracture and rest for the soft tissue. Now, after 7 days, the soft tissue swelling reduced, so he was taken into operation theatre for definitive fixation. Now you can see there is fixation of the proximal tibia with a plate and transverse patella fracture by tension binding wearing. The fixation has been pretty good. The external fixator has been continued for more soft tissue healing. Now the course of this patient in the hospital remained totally uneventful. He was discharged from the hospital and the external fixator was removed at 6 weeks. So for the time being, for next 4 months, patient was not allowed weight bearing. Now after 4 months, patient was asked to allow bear weight on the operated limb, but he couldn't. He had persistent discomfort in the right lower limb, so left lower limb. Now the treating doctor suggested him to continue the same treatment, continue more of rehabilitation, and he was assured that he would be able to bear weight. After 6 months, the same problem persisted. Patient had persistent right knee pain, hip discomfort, and difficulty to bear weight, and he had a shortened limb length on the operated side. So again, he went to the treating surgeon. He was also assured that fracture are getting healed. You need to give it more time. Now patient went into for consultation to 2 or 3 more orthopedic surgeons. Everybody looked at the knee and then dispatched the patient back to the operating surgeon, telling the fracture is getting healed. Everything will be getting normal day by day. Now after 6 to 8 months, after 8 to 10 months, patient again reviewed to the operating surgeon. Then he was ordered this X-ray, but the operating surgeon still did not find any abnormality in this X-ray. Now patient went to another orthopedic surgeon where he could diagnose something abnormality in his hip. Now from that surgeon he was referred back to the AIIMS almost after 1 year of his injury. Now here we can see on the left side the femoral head is contained inside the acetabulum. It is a ball and socket type of joint. The ball is contained inside the hip joint. On the right side, the femoral head is outside the socket, that is the acetabulum, and the patient had this problem for last 1 year. Nobody could diagnose it. Now I would like to invite my radiology counterpart, Dr. Nikhil, SR Radiology, to take you through the CT and pre-operative CT and X-rays.
Good afternoon to all. So now I will show you the preoperative X-ray of the pelvis. This is the AP radiograph of the pelvis, and grossly we can see that there is a slight pelvic tilt. The right side of the pelvis is slightly tilted cranially, and the glaring finding is the right acetabulum is empty, and there is non-united fracture of the posterior superior aspect of the acetabulum, and the femur is displaced cranially. And in the iliac bone, here we can see that there is this pseudoacetabulum formation, pseudoarthrosis formation, and also cranially to the femoral epiphysis, femoral head, there is this ossification, which can be a heterotopic calcification in the soft tissue, or it can be a fractured fragment. That we have to comment it on CT. So these are the 3D VRT images of the same patient. As we can see, this is the right hemipelvis, which is punched out from the VRT image. And as I have pointed here, the right acetabulum is empty, and also there is this fracture which is involving the posterior wall as well as the entire posterior column and the wall. And there is union in the inferior aspect involving the ischial part. However, along the posterior wall, there is non-union and also with slight external rotation. And the femoral head, as we can see, it is displaced posterior superiorly, and surrounding it there is heterotopic calcification. So this was in the previous radiograph, it was doubtful whether it is heterotopic calcification or a fractured fragment. But as we can see, the calcification is almost encircling the epiphysis. So this is a heterotopic calcification. And slightly rotating the image, we can see that the fractured border is smooth and well corticated. So the heterotopic calcifications and these well corticated borders suggest a old chronic fracture. So this is the summary based on the two images, X-ray and the CT. Old malunited displaced fracture of the posterior column and wall of the acetabulum, with superior and posterior displacement of intact femoral head and pseudoacetabulum formation. Now Dr. Abhijit will continue.
Thank you, Nikhil. So we have seen it that the initial surgeon more or less focused on the knee and totally missed the hip fracture. It was a quite significant fracture. There are many reasons to it. We'll dive into the literature search, how common it is, what are the risk factors, and how it can be missed. But before that, let's see what happened in this case. So there are a lot of surgical challenges here. The first challenge more or less has been summarized by the radiology. But if you see here, this is the first challenge. So this posterior column has been rotated and it's non-union proximal. Second challenge is this hip is lying here for the last 1 year. It is not in the sternum. It leads to the soft tissue contractions. Third challenge is there is a non-union and there is a rotation which places this hip in a different position. So normally our acetabulum is placed in a way that it produces some kind of support to the ball so that it don't dislocate. Now this posterior column has been rotated and malpositioned so that even if we place this hip down there, the position of the acetabulum is like this, that it leads to a dislocation of the hip. Third challenge is the non-union hip. So the first thing coming to the mind is why not to put this hip back where it belongs and put all the fragments together. But it's not possible at 1 year because at 1 year this cartilage loses its overall strength. Even if we put the head, if the cartilage is normal, we put this head back to this position, it will lead to chondrolysis and the posterior column osteotomy and replacing the posterior column in a right position is not a easy way to do. The plan was to fix and replace this hip, and this is how we proceeded. We use this femoral head graft as our as our important thing, in which we place this femoral head here. Then we put these screws into the anterior column and the ischial tuberosity. If you see here, so these are the screws which are going anterior, and these are the screws which are going posterior to the ischium. The next step was to give shape to this acetabulum. So if you see here, this femoral head has been weaved to give a shape to the acetabulum, and then this very special implant, which is known as trabecular metal implant, which is highly porous, and we can make multiple screws in a desired direction. So this cup was placed here, and superior screws and inferior screws were captured to get a good fit into the cup. If you see here, this cup is not an ideal position. It is very vertical and it is retroverted, but it is intended to have a best contact with the spool. The third step was, as this fragment is doing two things. The first thing, it is bridging the non-union. Second thing is it recreating the posterior column. So it can't be left alone. Now all the stresses cannot be taken care by it. So the next step was to add some kind of augment or buttress to it. So the augment was used, and this was the final construct. So this is the cup, TM cup. This is the overall dual mobility shell, which has been lined into the desired version and inclination. This is the augment which has been placed to hold this head together. So this was the X-rays. If you see here, there are the suture line here. These were the initial post-operative X-rays. This is 1 year post-operative X-ray. And this is the video we have taken just before the CCM. Now he's back to the community. He is doing his job. He is able to walk unassisted. Mind, he has 3 fractures here. One is the hip, which we have replaced. One was in the patella, and one is the tibia. He still has some kind of pain in the patellar region because of non-union of the patella, but we have not addressed intentionally because it has limited disability because of it. He is able to stair climb. He is able to come down. He is able to sit. He is able to do whatever he wants to do. So I want to request Dr. Nikhil again to discuss about the post-operative radiology, how the CT scan looks like.
So this is the post-operative anterior posterior pelvic radiograph, and cranially we can see that there is metallic augment which was fixed with the screws, and also inferiorly there is this total hip replacement prosthesis. And the epiphysis, which was used for the reconstruction of the posterior wall, could not be visualized in this radiograph. So we went for a CT, and these are the coronal sections showing the total hip replacement prosthesis, and this is the metallic augment. And in this section, we can see the femoral epiphysis, which is fixed with a screw to the acetabulum, and this is used for the reconstruction of the posterior wall. The same can be seen in the axial image also. And this is the 3D cinematic VRT image, where I have pointed the metallic augments in the lateral aspect and also from the posterior view. This is the metallic augment, and this is the femoral graft. Though it is not properly visualized because of the artifacts from the metallic objects, but grossly we can appreciate the structures. Dr. Vikrant will continue.
Thank you, Nikhil. So more important here is to not to discuss the success of this case. More important how you can miss such a misfactor. What the literature says, as an orthopedic surgeon, is it very common for us to miss a fracture, or it is a process rather than a person? So the obvious reasons what we were able to identify were that the surgeon primarily focused on the obvious injury because it was the same limb. There was a massive soft tissue injury to the knee region. So he focused on the obvious injury and completely missed the hip examination. Second was he did a complete examination of the whole limb. Third, he never ordered proper X-rays. Even if the X-rays were ordered, he missed the occult fracture. And because of lack of diagnostic modalities like CT scan, this gradually got even worse. So the two questions here: how common is this scenario, and how this could have been avoided? So I want to invite Dr. Love from Trauma Center. He's a colleague from the Trauma Center. He tell us how common is this and how we can avoid this.
Good afternoon, everyone. Myself, Love Mehta from Trauma Center, Orthopedics. So, missed injuries in the emergency department, is it quite common or not uncommon? Let's find out. This is a case from our own trauma center where a 40-year-old patient who sustained polytrauma, he was primarily managed at an outside hospital where he had an ICU stay for a few weeks, and he subsequently underwent fixation for his upper dorsal spine fracture. And patient also complained of left upper limb symptoms with pain and decreased movement, but his symptoms were attributed to the spine injury. Patient came to us in our OPD after 3 months where the dedicated X-rays of shoulder were done, and it was found that he had proximal humerus fracture dislocation, which was initially missed. Further scans were done which revealed persistent dislocation and a 4-part posterior fracture dislocation of the proximal humerus along with signs of now malunion. So what does the literature say about the evidence of what is the evidence about the incidence of the missed injuries in emergency department? There are numerous studies done which have shown that the missed injuries in the emergency department is not a rare phenomenon. This was a study done at a level 1 trauma center by Hussain et al., where the incidence of overall missed injuries was 8.1%, and it included injuries to all parts such as head, face, thorax, abdomen, spine, pelvis, and extremities. But what is the burden of musculoskeletal injuries that are missed in the emergency department? In the study by Ju et al. In South Korea, he found that the overall incidence was around 8.2%, and among these, most of them, around 82% of them, were the fractures. Also, this systematic review was done, published in JBJS by Stevens et al., where the overall incidence was 9%, and the proportion of the missed injuries that were musculoskeletal ranged from 45 to 80%. But per se, the incidence of missed fractures in the orthopedic practice is around 1.4 to 3.4%. Now, which are these fractures which are being missed in the emergency department? Mostly these are the small fractures of the small bones of the hand and metatarsals, followed by distal extremities such as distal radius and distal tibia. Although we think that we have managed the life-threatening part and the major part of the injury, but these small fractures of hand and foot make the patient more morbid in the later part. So the risk factors which can lead to missing of these injuries can be classified either into the patient-related factors such as high injury severity score initially, altered mental status, history of ICU stay, or it can either be the physician-related factors such as inadequate initial clinical evaluation, misinterpretation of the radiological test, and presence of any distracting injury as seen in our case also. So what went wrong in this case that we had discussed today? There was a tunnel vision on the part of surgeon where he focused only on the knee part, which was very obvious. No pelvis imaging was done at the first presentation in ED, which is usually a protocol when the patient is triaged into yellow category, also red category. And also there is a dictum in orthopedics where whenever we feel there is an injury to a part of a limb, we have to get the x-rays done of the one joint above and one joint below, which was not done in this case. Pain, the patient's groin or hip pain was overshadowed by the knee injuries, also due to lack of adequate training and supervision of the treating ED physicians there, eventually leading into the missed hip injury. So after discussing these missed injuries, we have to see how to avoid these. Here comes the role of the comprehensive protocol such as ATLS, which was developed in the 1970s by the American College of Surgeons for initial evaluation and management of the critically injured patients. So what is this ATLS approach? It is done in the sequential steps of triage, followed by primary survey with simultaneous resuscitation of the patient, followed by secondary survey, then monitoring and reassessment, followed by tertiary survey, and finally the definitive care. Primary survey is a rapid assessment of life-threatening and limb-threatening injuries, which can be remembered by the acronym of ABCDE, which is airway plus cervical spine stabilization initially, followed by breathing, then circulation, then disability and exposure. It is followed by the secondary survey, which is done with the same physician, where the initial head-to-toe examination is done, then systematic review and history in the form of ample is taken, and the non-life-threatening problems and missed injuries are seen. But are these primary and secondary survey enough for diagnosing all the injuries of the patient? Various studies have now shown that range of missing injuries even after primary and secondary survey is around 10 to 15%. And now comes the rules of the tertiary survey. But what is the reason of missing injuries even after primary and secondary survey? As we know, the primary and secondary surveys are done in the trauma way, which is normally done under 10 minutes. And complexity of these severely injured patients makes these two surveys insufficient to detect all the injuries. So in 1990, the Anderson gave the concept of tertiary survey, which is a comprehensive physical examination of the patient, usually done within 24 hours of the presentation. But this tertiary survey has to be repeated when the patient regains consciousness in an unconscious or obtended patient. Re-examination of all the prior imaging is done and all the blood work is seen. And the focus is primarily now on the musculoskeletal injuries, which we feel were missed initially. Here is a prototype tertiary survey chart which can be followed to avoid missing any injuries. Now I would call Vikrant sir to take on this.
Thank you for enlightening us reasons and the risk factors for this case. So it was primarily a missed protocol than a person. It is primarily a process which was under our fault. So the take home message from this is the tunnel vision always lead to the missed injuries. It is not very specific to orthopedics. It is very specific to science itself. Second is time heals everything. This was the thing which patient was getting from his surgeon कि ठीक हो जाएगा थोड़ा सा time दे दो. But time don't heal everything. It can make things even more worse. And it is always better to tame a difficult injuries in a right time rather than trying to salvage in a very bad condition. And we should know when to not to make difficult things more difficult and know when. And especially it is not a person, it is a process. And this ATLS structured protocol based approach will increase the chances of early detection of the injuries and not missing the injuries. And let's not miss a patient for the bones. Thank you.
Other Indian studies, all the international studies were they have missed injuries.
Study from Nepal is there, but not
From India.
this could be a good case.
And that's why we got up. Student days that you have to from head to toe, even if the patient says you have pain in hand, you have to palpate and do with a certain force and create pain. Also, it produces sign. The problem is very disorder. When you don't do special problem is the patient is unconscious, the program is related. And this usually happens in polytrauma when the component of injury from a shock. We're not able to tell you, and all these problems happen more.